Remember the new U.S. guidelines for who should be taking cholesterol-lowering drugs? Well, the group that issued them are now reviewing whether or not they should be followed after fierce criticism for overestimating the number of people who should be prescribed cholesterol-lowering statins. It turns out that the new risk calculator, which takes into account age, race, gender, and heart risks such as high blood pressure and cholesterol, overestimated heart risk by 75 to 150%, according to new analysis that will be published on Tuesday. Victor Montori is a professor at the Mayo Clinic in Rochester, Minnesota, whose diabetes research has used statins, and he joins us via Skype. Dr. Montori, thank you so much for taking some time with us.
A pleasure to be here.
I want to take a step back, and I just want to know what your reaction when this new risk calculator that was, or guidelines that were released by the American Heart Association and the American College of Cardiology came out. What was your reaction to these new factors?
Well, there is a fundamental improvement in the guidelines that are associated with these new guidelines. The first improvement is that we no longer try to pursue a cholesterol level as the goal of our therapy. We have for a decade or more been pushing patients to try to get an LDL cholesterol, a bad cholesterol, down to a particular target. That's gone, and that's really good news. Because then it focuses on the second important thing about these guidelines, which is a focus on the patient's cardiovascular risk. And the third important thing about these guidelines is that it focuses on medicines that can lower that cardiovascular risk, not on medicines that can lower cholesterol alone. And so many patients have been spending quite a bit of resources and time taking medicines that can lower cholesterol, but that have not been shown to reduce cardiovascular risk. To this extent, the guidelines are superior to what we had before. But because they emphasize this idea of looking at cardiovascular risk, at what is the risk of a person in the next 10 years of having a heart attack, then the calculation of that risk becomes important, something that in the past was not an issue. That is why you're seeing greater interest in that calculator now.
So two Harvard researchers, Dr. Paul Ridker and Dr. Nancy Cook, ran some existing heart patients through this calculator, I suppose, to see if it worked the way it's supposed to. And their findings were that the calculator overestimated heart risk 75 to 150%. Can you figure out how that could be?
Yeah, and first of all, the question for, I think, the audience is that important or not? I think when one takes that story at face value, one gets the impression that these guidelines, perhaps just like the ones before them, have as their objective to make sure that every American takes a statin. And so to that extent, they're open to that criticism. But at the end of the day, what the calculator allows you to do is to figure out the ballpark. Where are you in your risk of a heart attack in the next 10 years? Are you close to 0? Are you close to maybe 10 in 100? Or are you more of a 30 in 100 or 50 in 100 sort of a person? Of course, the higher the risk, the greater the benefit of taking statins. And that is why it is important to calculate that risk. Now, in the example that Dr. Ridker and his colleague put forward in the New York Times story that I've read today, the example that they use is actually quite telling. They start with a patient whose actual risk is estimated in one way to be 4%, and in the way that is put forward by the new guidelines to be 8%. So it's double. But the question is, does it matter that it is 4 or is it 8%? And when we show to patients with the way we use it with a decision aid, we show to patients a graphic of what 4% looks like. And it looks like 100 people, of which 4 will have a heart attack in the next 10 years and 96 will not. So, and we do not know if the patient in front of us is one of the 96 or one of the 4. And if we offer all 100 of them a statin, what will happen is instead of having 4 people with a heart attack at the end of 10 years, we end up with 3 people with a heart attack, and 97 will not have a heart attack.
Dr. Montori, let me jump in and ask you this question, because I think this is also on the minds of people out there who are interested in this type of research, and that is, if in fact this calculator and then the new guidelines overestimates the heart risk, then that means that there will be people who will be recommended by their healthcare professional, their doctor, to go on statins, and perhaps unnecessarily. So I guess my question is, what's the danger in that, in someone taking statins that don't necessarily need to, don't have that heart risk?
Yes, so the point I was going to make is that the kinds of exaggerations that are being reported are within margins in which people will not make a different decision about statins. So I do not know what happens when the exaggerations occur at higher numbers, but I can tell you one thing. For the last 10 years, a lot of people at very low risk of heart attacks have been exposed to statins just because their cholesterol was high. That is over, and now we have to pay attention at the variation in risk that these calculators can provide. But no longer will low-risk people with high cholesterols be exposed to medicine that is unnecessary. If we have to choose a better risk calculator, that is a new problem that we have, and it's a good problem to have because we have at least 4 we can choose from, and not necessarily we have to use the one that came along with the guidelines.
I suspect this conversation is going to go on for quite some time. Dr. Victor Montori, thank you so much for your time and expertise.
Thank you, and take care.